HIPEC was developed as a combined modality treatment about 40 years ago when systemic therapies were largely ineffective. Can you change the slide? So first of all, HIPEC is a surgical therapy that is given in the OR by the surgeon and not the medical oncologist. Difficult cases where the platelet counts are low, the blood counts are low, but which regimen to use, what dose reduction to do, what is the duration, that is decided by us. It's not work. Can you just change the slide? I'll change that. So, previous slide. So about 30 years ago, PMP was treated only with palliative intent with a median survival of 2 to 4 years. And now with CRS and HIPEC, we are seeing a median overall survival of 16 years. Next slide, please. And many people have questioned the role of HIPEC over CRS alone. They've said that you don't need HIPEC. Now it's very difficult to conduct randomized trials in PMP because of the heterogeneity of the disease, and this is the best data that we have. This is a retrospective propensity score match study from the SOGI registry that clearly showed a benefit of HIPEC over CRS alone. And the benefit was seen in all subgroups, as you can see in the forest plot. Next slide, please. What we have to understand that obtaining these results is associated with a very long learning curve. This study showed that it requires at least 100 procedures to obtain proficiency in treating PMP. Next slide, please. And this is some of our data. In this, we are not looking at the peak of the learning curve, but we are trying to determine after how many procedures is CRS and HIPEC safe. You should not have any open and closed procedures, any unexpected morbidity. And the number was 40. So it requires a minimum of 40 cases to perform the procedure safely. This is our own data. Next slide. And so the three essential components of CRS and HIPEC are to get a complete resection, control the morbidity, and achieve a prolonged survival, which depends on your patient selection. Next slide. So at the outset, when you start doing this procedure, you need a multidisciplinary team. I'm a person who's changed 3 centers, and nobody understands the importance of this better than me. Without my radiologist and pathologist, I'm lost. If the pathologist calls a LAM a low-grade adenocarcinoma, then the treatment entirely changes. Similarly, the anesthetist and intensivist can make or break your program. And we often do not give too much importance to rehabilitation, nursing, psycho-oncology, but all these things can go a long way in improving the patient experience. Just next slide. Lastly, medical oncology is also an important part of our team. You do an aggressive surgery, the medical oncologist backs off, doesn't give good chemotherapy, and you don't get the results in high-grade tumors, not specifically PMP, but just in general. Next slide. So these are the SOGI guidelines that were published a couple of years ago, and they are very practical guidelines, and I would advise anybody who's treating this disease to just go through these guidelines. They tell you what to do for different clinical situations. Next slide. So a little bit about patient selection and prehabilitation. You will see 2 kinds of patients. Patients who have a good performance status. Actually, there are many animations. So just open all the animations. And this is what we do. We optimize the comorbid conditions, advise physical exercise, spirometry, nutrition, supplementation. It goes a long way to improve our post-operative outcomes. if the patient has a poor performance status, then sometimes we have to give TPN, and we can do a mini laparotomy, drain the mucin, and improve the performance status of the patient. Next. So a little bit about cytoreductive surgery before we go on to HIPEC. Next. So I don't know if this is very clear. Like if you are seeing an appendiceal tumor and there is PMP and it's clearly resectable, then there is no need for a biopsy. You can directly go for surgery. But if it's high volume disease, there are features of high grade, then you might perform a biopsy. In either case, most of the patients will be subjected to surgery upfront, and maximum tumor debulking is also an option for these patients. Next slide. So some contraindications for surgery: if there's extensive small bowel involvement and you cannot save more than 1.5 meters of the intestine, then it's better not to perform. I mean, you will have to do a maximum tumor debulking then. And this mesenteric involvement causing retraction of the mesenteric root is a sign on radiology that indicates you will not be able to get a complete resection. You might still explore the abdomen to do a maximal tumor debulking. Age greater than 75 years, in our scenario, yes. I would be very skeptical to do a surgery for such a patient. Aggressive histology, PCI greater than 20, maybe not an absolute contraindication. You can still get a 5-year survival of 50% when the PCI is high and it's high-grade disease. Involvement of the liver hilum, most of the times we get a complete cytoreduction there. There is a sign on CT where the perivascular fat is infiltrated. If that fat is infiltrated, you will not be able to clear the disease of the porta. But if the fat is not infiltrated, you will be able to remove the disease.
Madam, one question. So this was based on the voting, right?
This
so
is based on
half of them said that extensive small bowel involvement is absolute contraindication.
Absolutely. That's
so
what I'm saying.
half of them believe that they can operate.
See, you can, in PMP, removing disease has a benefit. So even if you do a maximal tumor debulking, the patient will have a survival benefit. It's unlike colorectal or ovary where a CC2, CC3 is absolutely not, it is an absolute contraindication. So you don't even open the abdomen in those patients, same with colorectal. Okay. So then is infiltration of the anterior pancreatic surface. Again, if it's infiltrating the parenchyma, then of course surgery is a contraindication, but it rarely happens in PMP. Ureteric obstruction, again, as you can see, not a absolute contraindication. Need for complete gastric resection, and maybe Dr. Ramakrishnan will cover it in the panel also. But I think that in our patients, it becomes very, very morbid. Because when you need to completely resect the stomach, you will be resecting a lot of small bowel also. So personally, I would try to preserve the stomach as much as possible. Distal gastrectomy is okay, but a total gastrectomy, it involves that patient will have a lot of disease on the small bowel. Next slide, please. So coming to the role of diaglap, it is the most accurate way of detecting small bowel involvement, but in can you just press? Yeah. So often in PMP, there is a huge omental cake, and you will not be able to assess the small bowel. So it has a limited role. Next. And most of the times, even when there is disease on the small bowel, you will go ahead with surgery. Next. So the other important thing is to plan all your major resections before. If I open the abdomen and this is what it is, I know beforehand I'm going to remove all the tumor. It's not like you go in and decide, oh, this patient needs a rectal resection or a splenectomy or gastrectomy. It is pre-planned. At least you know that you might need a gastric resection. As you can see in the lowermost image, the subpyloric space is involved there, and that patient will require gastrectomy. If you see the top image, the radiology image, in that patient you may still be able to core out the disease from around the stomach. But the thing is, you have to be prepared that this is what you are going to encounter. And counseling for a stoma. So for a temporary stoma, the patient has to be counseled beforehand. What to do in a maximal tumor debulking and what not to do. So you can remove the omentum, drain the mucin. Gastrectomy, again, most people will not agree. If you are leaving behind gross disease, then better not to perform a gastrectomy. Colonic resection, yes, as required. Diaphragmatic peritonectomy, again, it's a selective thing. If your only site of residual disease is going to be the small bowel, then you can go ahead and do it. But if you are leaving behind gross disease everywhere, then no point. Like if you are just doing an omentectomy and draining the mucin for symptomatic benefit, then it's no point doing a diaphragmatic peritonectomy. And HIPEC, again, personally, I would be very skeptical to do a HIPEC in a patient in whom I'm leaving behind gross disease. But again, there are some people who do it, others who don't. So coming to the procedure itself, next. So this is something that shocked the peritoneal surface oncology world 4 years ago. And this is a study from Germany that showed that for colorectal cancer, about 70 HIPEC regimens were being used. Different time, different duration, different drug doses. Next. So the SOGI and RENAP groups started a consensus on HIPEC regimens. A thorough review of literature was done, and regimens that are supported by phase 1 studies and pharmacokinetic data was selected, and there was a vote on these regimens. And before that, we've written this manuscript that described how these regimens were developed. So if you are actually doing HIPEC, it's a good manuscript to read where you understand how the dosing was, how the doses came up, how the duration came up, and what about the temperature. Next. So these are the 3 main components of HIPEC. Temperature, we use mild to moderate hypothermia. Perfusion, there is maximum and minimum perfusion time. Drug regimens, threshold and peak doses, stat or split dose, concentration-based dosing, and acceptable drug combinations. Next. So regarding the HIPEC machine, for a long time I didn't have access to a custom-made machine. We use this system. It works well, but again, you have to know the procedure very, very well. Next. Open versus closed method. Each has some advantages. In open HIPEC, there is more even distribution. You can manipulate the intestines. There is better perfusion of the abdominal wall, and you can address the small bowel disease during the HIPEC. One thing I would recommend is, the picture is not very clear. A lot of people put retractors on the abdominal wall during HIPEC. That is one thing you should not do, because you will not perfuse the abdominal wall. Closed HIPEC, it is safer because the staff and surgeons are not exposed to the drug. There is better temperature maintenance and some other pharmacokinetic benefits that I'll talk about. And it is a break for the surgical team. Next. So this is one study in which they raise the intra-abdominal pressure in closed HIPEC. When you raise the intra-abdominal pressure, the penetration of the drug into the tumor nodules will be more. And they found no difference in the pharmacokinetics of cisplatin, no increase in morbidity, but there was a better cisplatin penetration in the mesenteric peritoneum. So it would be interesting to see where this goes. This is just a phase 2 study. Next. And this is another paper that I've written with the French group, in which we found that in a certain group of ovarian cancer patients, closed HIPEC was doing better than open HIPEC. But again, this is, so far, all the published data shows that both are equal. So the thing is, you should do whatever procedure you have trained for and are comfortable with. Next. The next is what temperature? So the temperature that we use in HIPEC depends on the thermal enhancement of the drugs. Some drugs like paclitaxel and docetaxel undergo very limited thermal enhancement or no, and they are not used for HIPEC. Most of the drugs undergo moderate thermal enhancement: oxaliplatin, gemcitabine, doxorubicin, mitomycin C. And there are some super drugs for hypothermia like cisplatin and melphalan that you keep raising the temperature and their cytotoxicity increases. So what temperature we use in HIPEC depends on the thermal enhancement of the drugs. Next. So for most common HIPEC regimens, the intra-abdominal temperature should be between 41 and 43 degrees Celsius. Less than 41, most will agree is not probably HIPEC. Similarly, the temperature should not be more than 44 degrees Celsius because it leads to cell death. Next. So what is the ideal duration of HIPEC? Now the duration of HIPEC depends on the half-life of the drugs that we are using. But again, duration is important for perfusion because all your free intraperitoneal cancer cells, if you believe in that HIPEC works, if you believe the theoretical aspect of it, one of the roles of HIPEC is to address the free intraperitoneal cancer cells. That is why the duration of perfusion is important. Next. And so I will share some unpublished results from this consensus in which about 145 experts voted and 90 minutes was now the preferred time for performing HIPEC, and the duration should not be less than 60 minutes. So a 45-minute HIPEC, 30-minute HIPEC is now voted out. And these are, of course, unpublished results. They have to still undergo peer review and be published. Next. So how much perfusate to use? Some of us fill the abdominal cavity and as much of volume that is required to fill the abdominal cavity. Another way of calculating is 2 liters per meter square of fluid. Now this is an interesting trial in which they compared this body surface area based dosing versus concentration based dosing. So you just calculate the drug body surface based on the body surface area and add it to whatever perfusate you have used. And in the other arm, it is 2 liters per meter square of fluid and the same dose for every 2 liters. So you end up giving a larger dose in the concentration based arm. As such, in this trial, there was no pharmacological advantage and there was more systemic delivery of the drug to tumor nodules with concentration-based regimen. So again, this is an interesting development and we will see where it goes. Personally, I use body surface area-based dosing, not concentration-based dosing. Next. So these are some of the regimens in common use. High dose of oxaliplatin, 460 milligram per meter square for 30 minutes. Medium dose of oxaliplatin, 360 milligram per meter square for 30 minutes. And the other one is low dose of oxaliplatin, 200 milligram per meter square for 2 hours. Next. Next. And these are the mitomycin C-based regimens. There is the Sugar-Baker regimen, mitomycin C plus doxorubicin. Dutch high-dose regimen, that is triple dosing, where you give the, you divide the dose in 3 parts and give it at the beginning at 30 minutes and 60 minutes. And American Society of Peritoneal Surface Malignancy, low-dose mitomycin C regimen. This is concentration-based regimen. So 40 milligram for every 3 liters of fluid. And the Basingstoke low-dose mitomycin C regimen, that is a very low dose of 10 milligram per meter square. Next. So in the manuscript published in JAMA that looked at the effect of HIPEC in addition to CRS, 2 regimens showed a survival benefit and others did not. Of course, there are a lot of limitations to this study, but these are the results. Next. And these are the recommendations from the consensus. So mitomycin C high dose, oxaliplatin low dose, and the combination of cisplatin and mitomycin C, these were the regimens that were voted for use in PMP. The vote was in favor of closed HIPEC over open HIPEC, body surface area based dosing, and split over stat dosing. Again, this is unpublished results. These are unpublished results, and they are just guidelines. As such, we have no proof that one is better over the other. Next. And 2 regimens were voted out in this consensus, the Elias regimen of 460 milligrams per meter square for 30 minutes, and the low-dose mitomycin C regimen. Next. Next. So how I do it, I do the open method because I was trained to perform the open method. And initially, because I trained with Dominic Ilias and I was used to that regimen, I used that regimen, switched over to high-dose mitomycin C, and now with the JAMA publication, mitomycin C plus cisplatin. Again, I like a very hot HIPEC, 42 to 43, but of course, you can do 41 to 42. Next. And I do dose modifications. If it is extensive resection, then the important thing is that you limit your morbidity. So in a aged, frail patient, extensive surgery, I will do a 25% dose reduction if required. Next, please. Next. And when you do a dose reduction, you should keep this in mind. There is something called a threshold dose. So based on experimental data and phase 1 studies, there is a lower limit of every dose for every drug below which it is not effective. So if you are doing cisplatin 75 milligrams per meter square and you reduce it to 40 milligrams per meter square, it is not going to work. So you have to look at the threshold dose and you have to look at the peak dose that you do not exceed the peak dose. Next. So to conclude, CRS and HIPEC requires a specialized multidisciplinary effort. And appendiceal PMP is a rare disease that has orphan disease status and calls for treatment only in specialized centers to confer the maximum benefit to patients. Choice of HIPEC regimens and methodology should be conformed to the experience and comfort of the multidisciplinary team. Personally, I have thought of shifting over to closed HIPEC many times because of the theoretical benefit, but then our staff is trained, they know exactly what to do. So it is an exercise, to switch over. If you go from closed to open, not so much of a problem, but going from open to closed, of course, I'm very worried. The minimum standards of performing the procedure in terms of duration, target temperature, drug doses, and methodology should be followed. And the results of the SOGI consensus should help us standardize this procedure and limit the number of regimens in use. Okay, thank you.